bringing TB and HIV services to the people. Find all TB and HIV to end TB and end AIDS. This press conference is hosted by TB People Zimbabwe, CNS, and Global AMR Media Alliance. Global Alliance of Media, that the Global AMR Media Alliance, which we call in short GAMA. AIDS is not over. The theme says we have to do so many things. TB is not over. Why? We know that both are preventable. We also know that TB is curable and HIV is treatable. And we have tools to do this also. Yet, TB was not preventable for the 10.6 million people who got TB infection in 2022. It was not curable for 1.3 million people who lost their lives to TB in the same year. HIV was not preventable for 1.3 million people who became newly infected with the virus in 2022. It was not treatable for the 630,000 people who died of AIDS-related causes, and 167,000 of them died of tuberculosis. Where have we failed? We could have perhaps found, treated, and prevented TB and HIV differently and better. Unless we find all people with TB and HIV and link them to optimum treatment and care, we will never be able to end TB and end AIDS in the next 84 months, because that is the time left to end them by 2030. When TB and HIV services miss the people who need them, not only do we fail to prevent risk of untimely deaths, but also fail to break the chain of infection transmission. And it is also about equity, about having systems in place to reach everyone with the best of available diagnostics, treatment and care, as are offered to those in the best of centers. We have new WHO-approved point-of-care molecular diagnostics tests that can be deployed at the people's doorsteps and diagnose drug-sensitive as well as drug-resistant TB. And they are being used to reach the unreached. But the progress is slow and needs to be scaled up to help address inequalities, accelerate inclusion and innovation, which again is the theme of ICASA 2023. I would like to stop here and hand over the mic to Tariro Kudatsa, sorry for the mispronunciation, founder of TB People Zimbabwe, to give her opening remarks and do the honors to also do the Africa launch of Global Call to Find All TB to Stop TB. This global call to find all TB to stop TB was launched on November 3 in Goa, India by TB People India. It already has 300 endorsements just in 1 month, many of them from Africa, including Zimbabwe, and some of them are here in this room with us today. Welcome, Tariro.
Thank you so much, and welcome everyone. As you heard, I am an advocate, not just on national level. I'm an advocate at regional level, global level. I work with many partners in TB. So on 3 November, Africa launch of Global Call to Find All TB Stop TB partnership, and I was part of it. There's a lot I've learned from there. As I stand here, we cannot lie, the voice of TB is silent, especially in Southern Africa. It's so silent. And when I met with the TB people, global and so forth, they said, we want chapters in South Africa, we want a chapter in Botswana, we want a chapter in Zimbabwe. Can we do that? I said, yes, we can do that. So today, around 7 o'clock, I saw this call. I even also didn't know. I didn't know. I saw the call on the WhatsApp and my email to say, today we are going to launch through Gamma, through Stop TB, Global Stop TB. So what is TB People? TB People is is the global network of people affected by TB, which was initiated in 2016 in Slovakia, and I think it was registered in 2018. The vision of TB People is a world free of TB. So what do we want to do as TB People? It's just taking TB and HIV services to the people. That's the whole thing. Take TB and HIV services to the people. We understand the scientific language. We understand the mathematical medal language that they are missing TB people. They are missing children with TB. But I am saying from communities, it does not make any sense to say we are missing. We are there. Are we not there? People with TB. We are there in our compounds. We are there in our artisanal miners. We are there in our farms. We are everywhere with our dust, with our silicosis. What is missing is the service. So as TB People, we are saying, let's bring services to the people. Once we bring those services to the people, we will never talk about it, missing NTB or missing N targets. So TB People of Zimbabwe will work through Stop TB Partnership. I'm a member of Stop TB Partnership. And today I'm so grateful and I'm so happy, especially the people from Zimbabwe. You are going to understand me for TB today, because today I've got my sister there. Stand up, my sister. Yeah, and you, my sister, also stand up. Yes, yes. This one knows the history where we came from. For us to have Step TB Partnership, we ran in South Africa. People pouring pain on us to say TB should be a community disease. Am I right? And we were challenged to say, go back to your countries, make people sign. Here's chapters for TB Partnership. Now we've got a vibrant TB Partnership in Zimbabwe. The coming of Gamma, the coming of TB People of Zimbabwe is not to compete. No. We are part of Stop TB Partnership. But we want to enhance that voice of TB affected communities in the communities. Hence, Stop TB Partnership. Do the technical things, give us the tools and so forth. Is want to enhance that voice to end TB. End TB, just say yes we can. End TB? Yes we can. End TB? Yes we can. Before I sit down, I want my colleague, Caroline Maposhera, to come and add also there to beef up TB People movement. Caroline Maposhera, please.
Thank you very much, Tariro. All I can say is, yes, we can end TB. And yes, we will. We will do it. Yes, we know we've just got 88 months to do it. And we will do it. Once the services come to us as people, we will do it.
Thank you so much.
Hi, everybody. My name is Lucica Dițiu. I'm the Executive Director of the Stop TB Partnership here in Geneva. I want to bring my greetings to everybody there in Zimbabwe. Obviously, including Bobby and including Shomna, our friends for a long time. Thank you, Bobby, for not giving up and pushing the agenda forward. And I want to thank our colleagues and friends from Stop TB Partnership Zimbabwe, as well as the colleagues from TB People from Zimbabwe as well. From the Stop TB Partnership, I want to just share 3 thoughts with you, very much linked to this topic of basically diagnosing as early as possible and treating people with TB and people with HIV to ensure we end these diseases by 2030. 84 months left to achieve this by the end of 2030, so not a long time. As you all know, in September we had the UN high-level meeting on TB, And we managed to have in it, I would say, is probably the best of the three declarations that happened to the topics that took place in September this year in New York. Our declaration has very concrete targets, has very concrete deliverables as percentages as well as numeric ones to be delivered by countries. And today, the Stop TB, just today, the Stop TB partnership will launch the country targets, which basically, if we want to achieve the enrollment and diagnostics and treatment of 45 million people with TB, including people with TB and HIV, by the end of 2027, every country will have to contribute their share. So today we are launching the share, estimated share per country that we are having to be able to, for everybody to contribute. So I am making this announcement here, prime time, breaking news, that country by country, we have this, they are already on the Stop TB Partnership webpage, and we are sending a news alert as we speak on this topic. So it's very important. These are not, how to say, set in stone figures, but these are estimates, and they have the intent of generating a conversation in each country to put ambition, but also to put the country colleagues and stakeholders to think. They might not be the right numbers created from here, from Geneva, but let's have the right numbers that each country will develop and have for their own. The second point I want to make is this. In the African region, we have huge TB HIV co-infections, up as high as 68%. Malnutrition and nutrition is another reason for prediction of high rates of TB, as well as very bad prognosis under treatment. Unless we are wrestling together to address the topics that we are said, we will not be able in African region and globally to end TB, to end HIV, to address malnutrition and so on. So these days we have people living with HIV, living long lives. 1 in 3 is killed by TB. We will not be able to reach the end of HIV/AIDS unless addressing TB. We are not able to end TB without addressing HIV. It's not a brainer. We speak that for a long time. We are not there. There is still parallelism. There is still not enough getting together. I hope that the fact that the money are becoming less, which is a very negative development, but it's a reality of our days, as well as the entire political and economic environment in which we operate, will push us to work much better together. Because if we want to bring the services closer to people and diagnose people with TB, people with AIDS, as early as possible, we need the services to come so close that there will be no barriers between the people and the service, because now we have a lot of barriers impeding people to address the health services. So the only solution we have is to work and support each other. It's the only way forward. I'm happy that you will have this conversation. I am happy that at ICASA there were few conversations on TB, not enough. I hope we will have more in 2024. And from Stop TB Partnership, we remain very committed to what we decided to do for a long time, which is empowering people affected by the diseases to have the central role in developing the answer towards ending TB, ending HIV, ending malaria by 2030. Thank you very much for giving me this opportunity to speak, and I hope that will be a great gathering. Thank you.
Good afternoon, one and all. Coming from India, the world's TB capital, the one area that we've managed to overtake China. It's not a very nice feeling, but that's the reality that I bring into this room. My take on TB as being part of the industry that has been providing tools for, as Luchika says, very early diagnosis of TB has shown me this, and this is my experience of the last 3 decades that I've been involved, that for diagnostics we have always been very dependent on a lab. Our diagnoses have always been very lab-centric. However, I think one of the learnings that we can take from the pandemic, which hit us so badly, post the pandemic, there has been quite a global consensus that the diagnostics now need to reach the people, go to the people as close as you can. So I think that is one of the great things that the pandemic has taught us, and we are very happy to be part of a solution that enables tools to go very near to the patient. However, in the last 3 decades, there has also been another learning for me in person, is that whenever we've talked about technology going to the people, there has always been a kind of a trade-off. That technology that goes to the point of care sometimes or very often lacks quality. But today again, we are very, very happy to tell you that we have now tools across the globe wherein these tools are going to the last mile possible right into your communities, and they are probably at par with the very best that you can have in a centralized laboratory. So much for the industry. I think I will stick to the India scenario, and I'll just like to tell you what, as a country with the highest burden of the TB, as a country that we are doing. So pre-pandemic, we had, by and large, India has about 15,000 odd microscopy centers, which were doing the test on with the smear microscopy, which is the first choice test that there has been for decades. As of now, as we speak, the consensus among the government is that, of course, you all know that the WHO mandate is to replace the smear microscopy with a molecular test. And India as a country has decided that each of these microscopy centers, right at the block level, will mandatorily have a molecular testing facility. So as of now, as I speak to you, India as a country has nearly 7,000 facilities that offers molecular testing for TB and other diseases. And out of these 7,000, roughly 5,000 are in the government domain. You would also be happy to know that very recently, the Indian Parliament, which is the body that enacts all the laws, have given the government a very strong recommendation, recommending that the molecular test which is developed in India be put in all the direct microscopy centers and at a block level. So that is what the intent part of the government is. As Luchika says, political will, because that's where the money ultimately comes from, is very, very key when we have different stakeholders participating and collaborating together to bring this to fruition. So I'm sure as we speak, and there are so many speakers from the different countries who will share their experiences, I think the time has now come to kind of actionate more than ever what we've so far been telling ourselves, to find TB, to find all TB and NTB. I will go one step backwards, and I don't remember who coined this, but there is a very, very significant one-liner that I kind of vouch by. You know, this statement was, to find TB is to fight TB. Unless we find TB, we will never ever be able to, combat TB and forget about eliminating TB. So with this few words, I would like to rest for the moment, and we will of course discuss going forward. Thank you very much, Shobhaji, for this opportunity.
Thank you, Chair, and all delegates that are here. Firstly, let me say that I completed my tour of duty as Chief of Party. I'm now back to public service as the Commissioner for the Government Health Services Commission. Those of you that are aware of challenges of HRH, ministers of health and governments within our region agreed that we needed to separate health workers from the public service so that we can take care of their issues. So that's where I am there now. But with regard to the ICASA conference this week, I'm here as a board member for AMREF, Health Africa, the Malawi chapter, which is implementing a number of health initiatives to make sure that people live long and they have quality of life. And one of the things that we are looking at in that program is how do we play a critical role in ending TB
and HIV, and of course the package now is growing to include other NCDs. I just have 2 or 3 sentences for the meeting today. Is that we don't have any other choice but to end TB, because we have long development agendas that each of our countries are implementing, and we know that sick people cannot do any development work. So we need to make sure that we have interventions that are in place to make sure that these chronic illnesses, we do away with them. So what exactly do we need to do? We heard from my sister there, who gave us the information about issues of TB. We know the science, we know the evidence, what is all about TB, what it is all about HIV and AIDS, and we know we need to get to the people. But so far, from what we have been doing before, is that I'm also the guilty one, I'm a health worker, a clinician. We think the people should be coming to us with their problems, and then we manage them the way we know how, without going to where the people are. So I think today my message to all of us here is that let us take the services to the people, because that's where the people are, that is where we are going to find the problems. So how do we do that? Firstly, I think we need to take the new concept of patient-centered approach. If we have the patient-centered approach, we are going to package the services that we need to get to these people. I'll just mention a few of what should be in the package. One, we need emotional support, psychosocial services. We need to have information that is going to address stigma, because you know, if your neighbor knows that you have TB, they are likely to run away from you, the way they were running away from us if they heard that we had HIV. So psychosocial support is important. We also need information on the adherence to treatment and how we are going to manage side effects when they come. So with this package and the treatment and the diagnosis, what has been mentioned here, let's take these services to the people. I'll give you an example of what we do in Malawi. We have developed community sputum collecting centers right in the village, the places that we call hard to reach. I remember my professor when I was at school in the US, she used to call this place the unlovable communities. So let us put in community centers where people can live their sputum, and the community health workers. Luckily in Malawi, we have community health workers that we call health surveillance assistants. Currently now they are called the community diagnostic assistants, because now they do a lot of things. So these people are the ones that are managing these centers where the people can go and leave their sputum. But for us to encourage the people to come to these centers and deposit their sputum, is that we need good packages of information on what are the symptoms to look for that would motivate me or any other person to say, I think it is time for me to go to the community center and deposit my sputum. So we need to provide adequate information. Now, who are the right people to provide information to the community? We have learned a lot of information when we started this meeting on this conference on Sunday. And just today, 2 hours ago, I was in one of the rooms where we are talking of community-led initiatives. The community gatekeepers, we had a chief from Botswana. We had a king's emissary from Uganda. We had a faith leader also from Botswana. These 3 people have shared with us what the chiefs can do. You know, all of us from the Africa setting, I'm hoping also in India you have chiefs. Everybody listens to the chief. Yeah. If a chief says kneel down, how many of us are not going to kneel down? We are all going to kneel down. So these 2 chiefs that were articulating what they are doing, their role in looking at issues of health, is that these are the people that are giving information to the people in the villages because they are gatekeepers. They will be the ones that will be taking the information that if you have a cough of more than 3 weeks, you need to have your sputum tested. In this village, I have set up a community place where you can put in your sputum for testing, and then they can do this sputum through the community health assistants. They can now go to the primary health centers that are now having these microscopy mechanisms. I know one health center in my country that has a gene expert in the community. So this is what we should be doing. Should we ask the patient or the client that has given his or her sputum to go to the primary center where there is the gene expert? No. The results must be taken by the community assistant to the family and invite the family now back to the clinic for proper assessment and then setting up the treatment. Once we have put these people on the treatment must be given in the community by community health nurses or whoever we have put in the community to manage community health centers. So I think this is the time that we should revitalize the 1978 primary health care, where the people are at the center, and this is the time that we need to take the services to the people. I want to leave the floor by saying we, the clinically trained people, the community are our partners. We cannot manage each and every disease in the facility. Let's take the treatment, the surveillance to the community, and let the community leadership assist us in mobilizing the community to take up the services that will be taken to the community, either through community structures, through mobile or outreach clinics. But time is gone when we expect the client to travel 20 or 25 kilometers to our clinics, most of the time probably on foot or on a horse and whatever. Time for us to go to the people. Thank you.
Good afternoon, colleagues. Maybe just to correct, I'm Executive Director for Joint Alliance Welfare Organization. That's the organization that is hosting Stop TB Partnership Zimbabwe. So Stop TB Partnership Zimbabwe has got a chairperson that then oversees Stop TB Partnership. Joint Alliance is the host organization. But on behalf of Stop TB Partnership Zimbabwe, I want to acknowledge and appreciate the TB community for being at ICASA. ICASA is International Conference on AIDS and STIs. So many a time we've seen HIV conferences purely doing HIV business. But this time around, the TB community is here. And the TB community is saying it is the TB disease that eventually kills. But TB is a century-old disease. Ladies and gentlemen, TB is curable. TB is preventable. Colleagues, COVID came less than 5 years ago. Where is COVID now? Why are we not doing what we did for COVID to TB? So that is the elephant in the room. It is an elephant in the room because COVID came and it affected the wealthy. It affected the developed countries. It affected those that equally get money and extract resources from the poor countries. And then TB continues to be there and they call it the disease of the poor. Do you understand where we are? But because it's a disease of the poor, it's affecting us, those that are in low, middle income countries. COVID came, vaccines, within a few years, vaccines were there. What vaccine do you know and how old is it that is in TB? Which vaccine? BCG. How old is BCG? Why don't we have a TB vaccine? And yet within 3 years, we had a COVID vaccine. Not just one, with multiple COVID vaccines. So colleagues, it is for us to rise up and tell the developing world that we need to find solutions to this century-year-old disease. We need the solutions that go to the communities to ensure that we pick the cases and they are curable, and post the period of them being treated, we ensure that we eradicate, end TB. So for it to be possible to end TB by 2030, we need the resources, we need the tools, but most importantly, TB disease eradication also needs for us to fight the social determinants of health. So as long as there's poverty, right? As long as there is hunger, we cannot end TB. As long as there is overcrowdedness, we cannot end TB. So it requires both the social constructs as well as the health constructs for us to fight TB. Thank you very much.
Hello everyone. I think it's very difficult to speak after Donald, as the kind of benchmark he has always set. But I'm very happy to first of all see all our colleagues, and I think last time we met was either in Union, and before that in the UNGA that happened in New York. So I'll go back to the UNGA, the UNHLM declaration. I think it was very clear. Equitable access to screening, testing, treatment, and care. And I think what I'll try to do is maybe try to unpack the word access and equitable in a way, because it's a little more complex than it sounds. So just as a digital health partner working with almost in 40 plus countries with 100 plus communities across the globe, I think what I'll try to do is try to bring some of the collective voices from the communities. One common thing that we keep hearing from the community, and I see our friend Roderick is there from Vienna, so Donald is from there, from Jointed Hand, we work very closely. One of the common challenge is access to high quality screening and testing services. I think, and if I have to just walk everyone through just a simulation and walk through a journey of a day wage earner who is symptomatic of TB. Just imagine, and ma'am talked about traveling from 25 kilometers far away. Just imagine a person living 25 kilometers away from Harare, where the testing centers are, who is a day wage earner, who is a migrant population, and migrant also we are working on the PIMS project with the minder. If you keep adding layers of complexity, coming all the way to Harare, only to listen that his test results will be delivered the next day, which means he has to come back to this thing. So he not only loses 1 day's day wage, but also 2 days and the whole complexity. And plus he's a migrant worker, right? He might even move out. So what really happens, we can visualize there is a test result, which may be a positive test result, sitting in the lab, and this person never comes back. This is what a missing case looks like. Right? And this has been our experience even while working with the national programs. We have been supporting almost 20 plus countries through their case-based surveillance system. I think this is also a common gap that is coming out of the national program, be it household-based content investigation or PLHIV screening for TPT, or active case finding or lab-based surveillance. This is the same, the gaps that we keep hearing is gaps in screening and testing services. I think we were also there in Union. I think many of them who also attended Union. I think I was part of the panel where someone was mentioning that one of the leading cause of missing cases is delay in providing testing services, right? And again, I'm not talking about the gaps in just availability of testing devices, but it's so more complex than that. It's like ma'am talked about, and everyone here talked about, Ruchika talked about, it's more complex than just availability of diagnostic devices or availability of tests. It's stigma, it's discrimination. There's so many layers of complexity to get access to diagnostic services. I think, and this is, we're not just talking about an ideal scenario, right? If you again add layers of complexity, if we go back to, let's say, July 2020 Zimbabwe, right, when the peak of COVID, the only thing that was working well was service delivery at the community level. That was decentralized. That's the only thing that was working effectively. So I think, needless to say, that it's not only important, but it's crucial from a TB elimination point of view to have high quality diagnostic testing available at the community level, at the doorsteps of the people. Again, if we add layers of complexity of humanitarian crisis, what's going on around the world, I'm not only talking about Ukraine, Russia, or Afghanistan, but everywhere across Africa, right? It makes so complicated to provide access. So unless it is community-led and it is available at the community, it's really difficult to provide access to screening and testing services. And just from our perspective, who has been supporting more than 40 countries through their digital transformation, the way we look at the world from a, sorry, yes, the way we look at the world is, the ideal scenario, if I have to just describe from our perspective, looks something like this. You have, access to next. Yeah. Okay. Hello. This was. Yeah. From. Am I loud enough? Can I? Okay. I think I'll go on. I think. From our perspective, who has been supporting countries through their digital transformation journey, I think one of the way we see the world is where we can do self-screening and self-symptom check at the community level, either directly by the patient communities, or through peer support group networks. Once that is done, I think making low-cost, high-quality diagnostic devices available at a decentralized at the community level, and not just collecting data, but also feeding it into the surveillance systems that the countries already have. So in India, for example, we have Nikshay. So can these devices are connected to the surveillance system to support labs? While we are talking about access to TB screening and testing, I think we are struggling with access to microphones.
Hello.
Can continue? Okay. Thank you so much. Okay. I think I'll just continue. I think from our side, I think the way we see the world is that we have low-cost diagnostic machines at the decentralized level, which can feed into the surveillance systems and notify, and this is not just for the public health, but also help in private sector notification. And I think, and the innovations are out there. I mean, we heard about screening for self-screening. We have, innovations like Cuff AI, which can detect just the sound of cough. They can detect whether you are more likely, as a proxy, more likely to be a TB patient or not. There are molecular, low-cost NAC machines. We heard from Sumit on TrueNut, or even handheld X-ray machines like Prognosis or Cure AI, which can interpret the X-ray machine results. So the innovations are there. I think the idea is now all of us should come together and work together. And I think, and this is how I think we will try to address the 4 million odd missing cases that we have right now. Thank you so much.
Hello everyone. My name is Albertina Nyati. I come from Eswatini. Eswatini is a small little kingdom with a population of 1.2 million. And then let me put on my glasses so that I can talk more about Eswatini. Okay, Eswatini has a population of 1.2 million people, and then 3,900 people get infected by TB every year. The burden has reduced from 1,110 per 100,000 to 325 per 100,000 by end of 2022. Due to COVID, treatment coverage dropped from 68% in 2019 to 47% in 2022. And then we have 16% of missing cases. The treatment gap is 53%. And then we have a screening which is paper-based. As I've mentioned, I come from Swaziland, and I am a woman living with HIV and a TB survivor. In 1997, I was coughing. I didn't know what was the problem. I was getting thin. I was weak. I went to hospitals and nothing could help. So finally, I went to another hospital. I crossed the border, because sometimes we cross the border from Swaziland to get treatment in South Africa. So I crossed the border to South Africa, where I was then diagnosed with TB. So for me, it was vice versa. Usually, you are diagnosed with HIV and then you are screened for TB. But for me, I had TB first, and then the doctor said, let us test for HIV. That is when I discovered I was HIV positive. I was cured. I was given medication because obviously I had the symptoms of TB. I was cured. And then once again in 2014, I got sick. This time, I didn't present with the usual signs of TB. The only thing that I could tell was that I was feeling very weak, and I didn't know what was the problem. I went to the hospital. They tried everything they could do until I was bedridden. So I used to get sick each and every evening. So every evening I would go to the hospital. They would let me sleep there. They would do all the tests. There was nothing that was a problem. They couldn't find what was wrong. Until at last, one doctor said, we've done everything we can do. So now let's just test for TB. And that was how I discovered I had TB, which is extrapulmonary TB. So from there, the journey to being cured began, and I was cured. That's why I'm standing in front of you. So with this story, I'm trying to say it was easy in 1997 because I was coughing. But in 2014, I nearly died because of maybe the screening for TB was good. Because I would go to hospital. Sometimes they would ask me, the screening, TB screening is paper-based. You go there, they ask you, are you coughing? Are you sweating? Are you what? And sometimes you haven't noticed that you are already sweating. And you don't present with a cough. So that is why my TB was missed. So having been here, I walked through the stand there, and I found the one stand that was having, they were talking about a molecular TB screening test, where they say that it can, instead of using the paper that we use, we can screen using a molecular test. So for me, that was a win, because I've been looking forward to something that is going to help us to be diagnosed, because with the paper, we miss a lot of cases, because it's just a paper. And in most cases, people come to the hospital, they are rushing, so they will just say no to everything. But with a machine like the molecular machine, I feel like if we can use it for screening, then it means all the cases that we are missing are going to we're going to find them. And also, I asked the guy to talk more about the machine, And then they told me this machine, it is easy to carry, and also it is battery operated. And they showed me a small machine, so I felt like for TB we need more of such machines, something that I would carry and go to the soccer field when men are watching soccer, and I will be able to screen them with something that is going to show me that someone has got TB. Something that I'm going to carry to the dipping tank, where males are there tending to their cattle. I will sit there, use my battery, and I will be screening everybody, not asking, but physically screening and telling them, referring them, having seen that there is something that is wrong with them. So I feel like for me, this is a win as a person living with HIV and as somebody that missed death by an inch because of maybe not being properly screened. Ladies and gentlemen, I would say we need more of such innovations so that we can ensure that we end TB by 2030. I thank you.
Yeah, have been working in the region, especially the Southern Africa region, around TB for over 8 years. And I've moved around all the countries, over 16 countries, just looking at the challenge that they face, and I'm the current chair for the Global Fund grant that is currently being implemented in the Overseas chair, working with Ontario. Donald posed one of the things that I've been asking myself for quite some time around that if COVID-19 got a vaccine within 2 years, and for me, for my country, it's not just because the rich were mostly affected, but back to my country, there is a lot of resources allocated to deal with COVID death from within. And I could see it starting with the healthcare workers, the allocating the facilities, lots of things were very directed to deal with COVID. But when to give you the answer that it's not that we don't have resources within our countries to deal with this issue, it's because there's no will to do that, especially for the political will. So how do we raise that political will to ensure that everyone is part of the response? For a long time, TB has been looked at as an issue for the Ministry of Health or for the National TB Program. And we are speaking about key vulnerable population. These are not, they are not just not from the general population, they are from someone. There's a sector that is contributing to those key vulnerable population. We have the mining sector. That's where there's miners, especially in their countries. There are people from labor. There are issues from fishing. Some of our countries, we have very large lakes and oceans, lots of fishing. So each sector has got people that is contributing to those key populations. So how do we ensure that this sector that is contributing that is also part of the TB response? Another thing that has been challenging, I was looking at the Global Fund, the GC7 that my country submitted to Tanzania. 80% of the grant is around procurement of drugs. And then the other, when you go back into details, you find that only around 1% is allocated to prevention. So how are we going to prevent TB if we're only concentrating around treating it? So I think it has reached the time we need to also think around preventing TB. Another area, so as we are looking around the world, there are lots of challenges. We can see there's war in Ukraine, currently in Israel and Palestine. So resources are shrinking. We cannot continue depending on external funding in order to deal with our issues. So this is, as advocates, we need to come together and ensure that there's enough resources available for people to access services, resources that are within our own and we can also sustain. Key populations, most of the time we find that it's not their fault that they are unable to access services, some because of what kind of work they do, And some of them are very indigenous. For example, back in Tanzania, we have the Masai. I don't know if you know Masai. These are people, for us, we see them as primitive, and most of the time because we do speak Swahili and they don't understand the language, they have their own language, and as they don't understand the kind of information packaging that we have is not the community-friendly language, so they don't understand. So as a result, they are vulnerable to the disease because of that. So dealing with issues around key population, we need to understand what are their needs and also take services and tell them according to their needs. It's not me sitting in my office deciding on what should do high-tech to maintenance, but ensuring that maintenance are part of the thing that I'm planning to give them so that they can give their views on the kind of service that I've provided. Thank you.
But I thought probably we can trigger our reflection. I don't think it's not that the communities are wrong or the healthcare workers are wrong. The issue is we need to sit together, and we're practicing Christian. And somewhere in the Holy Book, the Lord was saying, let us sit together and reason and come forward. So I think, like we are saying, let us, we, the providers that know the science, let's sit with the community together, share this problem, and come up with a solution that is going to guide us. We are here advocating that let's take services to the people. For example, surveillance. Let's go to the community and identify who is at risk and who has the problem, and let's see how we can package the services and take them to the people. So the community and ourselves, we should sit together, develop an action plan that all of us agree to, and we have each other's obligations, including what the duty bearers should do. Like my brother here from Uda has just said, probably we have the resources. Are we putting in enough? Global Fund gives us money, or PEPFAR gives us money, 80% for prevention, and only 20% for prevention. Then probably let's go to the national coffers so that we can finance the preventive part, because we know prevention is better than cure. Thank you.
Anybody else?
I think one of the reasons which I also feel is having access to information for evidence-based decision-making and policy at the national level. Not just at a national level, but also sub-national and lower up. Because we all know that anything that cannot be monitored, cannot be measured, you can't bring change. And one of the essential part of monitoring is having real-time access to information. I think, and I'm not talking about only the programmatic information, but also information coming from the communities, the consolidated voices from the communities on what are those gaps, so that people, the decision makers, can actually look at those information and can take the right action. So one of the reasons I see is also lack of data for action.
So as Shobhaji said, the call for finding all TB to end TB happened in Goa, the place where we are based. And one of the things that came out is that it is time that the community started demanding rather than asking very politely. It's time that you start demanding, and just as you mentioned, if the Global Fund funding is so skewed that 80% goes to treatment and 20% is towards everything else, knowing for the fact that everything starts with the diagnostics first and then the treatment, and I think the time has come for the communities to say, hey, look, we need more money for testing. We need more money for sharing information within the communities. So I think as we go back to the communities needs to come back to us in equal measure. When I say us, is the funding agencies, your governments of the day, the healthcare providers, people who are in the know, and say, look, you know what? We need to have more because we deserve better. So I think as communities, the time has come to stand up for your rights.
Thank you, colleagues. Thank you, colleagues. It has been an informative afternoon. TB everywhere. affects everyone. We have had relatives, we have had TB. We also have TB survivors here. And I say thank you. And I say thank you for building this movement. For building this movement. The TB people belongs to the people. We have had jointed hands, hosting TB partnership. These are people who are known in the community. They are known in the media frequency. We also have hand nomination to lead the Zimbabwe chapter. Where comes from the work that she does. It wasn't a position where one applies. It wasn't a position where one applies, but it's a nominated because someone has seen the work that we are all doing. She was there from massive work. She's doing massive work within the community. From my sister, everyone. If I don't mention you, it's not deliberate. You are also doing awesome. As we launch the people, the Zimbabwe chapter, let's go out and find the case. Let us not stigmatize people. Wow, the moment someone is they are no longer infectious. They are no longer infectious. He doesn't know that it's infectious. And that person doesn't know because they need to go this hospital when they are our TB is diagnosed when someone is that should be the moment. How can that be done? That will be done when the tools and diagnostics are molecular that we had of here. It's something that should be taken. For example, in Nigeria, they now have this new X-ray. Imagine the moment I hear one X-ray, I know I speak of basic because it's a big massive thing. But right now with the innovation, portable X-ray, which diagnosis taken to the communities in Nigeria. This was announced land conference and Dr. Kibaiwas and other people who are friends of the conference. They know that the clinic can be taken to the hospital can be taken. If it can be taken, you also mentioned we can even imagine people going to watch a soccer 9 tournaments. 90 minutes and they are screening within 45 minutes. Their results are made and you will not miss any case. If we are to end TB in 5 these people are they are not in bed of TB. If we talk of someone, we think of someone, we look at someone who is already validated cases, but the TB cases right there, they are there in the community. They are there and we have to find them. So if I am to say I want to go to the United States to be screened for TB. I'm not screened for HIV. Why am I screened for TB? It's a disease that they imported. They are scary disease. It's a scary disease. So we are doing something. We are not wrong enough. We are not doing enough to end TB. We can only end TB. Everyone is the moment I mention TB, and if I cough and I mean everyone in Zimbabwe knows of TB. So it's something that people know, but are we diagnosing it before the end? When it was mentioned that in Zimbabwe is screening. Are you coughing? Have you lost your appetite? If the technology gets better, you don't need everything to have those symptoms. It can peak and the gene except that's one machine that has been used for TB. It was only a ICASA that the gene is tested for hepatitis B, also test for HIV. So I always like to simplify machine, the gene extract machine becomes the oven. Because all you need to do with the genetics that you have to keep changing the hepatitis. If the hepatitis cartridge, the appropriate cartridge, the appropriate cartridge, you put the appropriate cartridge. You are testing an injection cartridge, appropriate cartridge. I simplify the aspect to say I want to make bread. I want to make bread. I make my bread dough. I get I put it. I want to make cakes. I want to make my bread. I take my bread, my preparation, put it in my tray. I have my cake roasted. I want to have roasted. I take my chicken into the oven, and have it. It's a gene extract machine. It's a multiple machine. We should now demand that those countries be found in hospitals. Because they usually get in their told the gene extract machine is here, but we don't. We should demand that all those multiple stages and we can end if we get also that small X-ray that is being used in Nigeria for Zimbabwe, we always have prevention, Thank you. This is the X-ray. We always know the X-ray trace, something a line facing up, but this is the X-ray. Thank you very much. To be portable. Imagine our community health. We call them right. They are carrying at machine. They are how many cases? 0 cases. 0 cases. The machine portable. The machine is portable. So thank you again for attending this. Thank you for coming.
Before thank you, there is a very important statement for the last, and we have saved it for the last. I would just like to add what Catherine has just said. She said, take hospitals to the people. There are certain machines which they are in the laboratories. How many of you have seen laboratories? Big yes. Right? They are in the big hospitals. WHO's also approved. Point of care, decentralized, lab independent, operate right here. See the magician. Get the C is right there. And you can do that. The X-ray which you saw is battery of WHO approved. It's WHO approved. And that's the so this is the whole machine. No air conditioning required, no electricity required. In Democratic Republic of Congo, it is used on solar power. This is a 2-nanometer machine. The only WHO decentralized point of care. Sorry.
There are platforms that are endorsed by the first being the expert. Great machine, or at least all the big awards that he has in Zimbabwe, we also have introduced and the 22 countries that are in Zimbabwe are at the extreme borders. Just imagine, this is our community. Just imagine within the walls, this is our sitting on a chair, and within the walls. Where the table, we will be able to test for each HIV, right in this setting, the least of the laboratory that we know in our lives. It is completely decentralized. The country of Zimbabwe has shown the way to the and what settings, some of the presenters in Zimbabwe they have shown some of the places I can picture you a pictorial street, but there is one side of a room, all the cows sitting, chewing their cud, on the other side, a stream of expectant presumptive cases waiting for their test, and the table on which the true nut is sitting is half eaten by mites. And this is a reality. So you can imagine when we say that the point of care, anywhere, anytime platforms are there, we are walking the talk. It is right in front. No electricity. Sunlight is the only thing that you require, and that is free.
as I said, it was used during COVID times, and whatever the gene expert kept, more than 40 diseases, just by replacing the cartridges. So, community needs to know that is important. There are so many scientific advancements, like HIV. We do not know that they exist. So it is important to take knowledge to the community, and then the community demands.
So the SOE NHP head Zimbabwe was with us, and he mentioned there is papilloma virus from human